Okay, so let's talk about special views of the forearm and elbow, and then also move into the lordotic chest, prone abdomen, and lateral decubitus abdomen. First up, we have two partially flexed AP trajections. It might be somewhat common to have somebody with an elbow injury and they can't flatten that elbow out onto the IR like we've been practicing. So what you can do, and which is on page 164, is a partially flexed elbow and partially extended, you might say. So if you check out page 164, you'll see what we have is a CR that is perpendicular and is directed to the mid-elbow joint. It's just that in one view, we have the humerus here flat down on the IR, and then the forearm kind of angled up, supported by this sponge, since the patient can't flatten the elbow. And then in the second separate view, now we have the forearm against the board with the humerus rotated, or angled up. And what that should do is, if you take a look at the x-rays in your book and here, we can see it gives the radiologist a little bit different peek or look at the joint. You can see how the small bit of difference in the joints look, and then the rest of the humerus and proximal radius and ulna as well, trying to mimic an AP extended elbow without having the elbow extended. So here's another one called the coil method, and that's going to be on page 170. In this case, you can see we almost have a lateral elbow, but in this case, the hand is just pronated, flat down, which is a lot more comfortable, as we've probably seen from positioning lab. But you've set up kind of for a lateral elbow, hand pronated now, and you've added a 45-degree CR angle going toward the shoulder. So coming in at that elbow joint, but pointing toward the shoulder at 45 degrees. And this is done for the radial head. The second separate view you would do is CR 45 degrees, but this time going the other direction, away from the shoulder. And the arm is a little different as far as flexion goes. It's at 80 degrees. So if I were to draw this, I would draw it. So previously we had 90. This time we have 80. So let's say, here was 80, sorry, hard to draw with a mouse, degrees, or you get the idea. It's a little less flexion than the other one. And then there's an alternative supine projection. This is where you really start to think critically. You say, okay, a patient can't go by the book. They have trauma, right? How am I going to get this x-ray alternatively? You could put the IR here, supported between the patient's arm and the rest of their body, and then come in with the CR in a different way. And again, that's the coil method. Trauma, axial, lateral, medial projection. So again, trauma, lateral. Okay, so into other special views. Here's the lordotic chest. The patient in this case stands about a foot away from the wall bucky and then leans back, if they can do this. If not, you may need to get a little critical thinking mode and use your IR to do the work that if the patient is unable to lean back. And you can see that on page 94, there's an alternative semi-axial AP projection. So go ahead and take a look at page 94. But anyway, in the meantime, if your patient can do this position, what you're doing is putting the CR perpendicular, MSP, just like normal, but this time you're going 3 to 4 inches below the jugular notch. And to locate the jugular notch and figure out 3 to 4 inches below that, maybe see figure 2.5 on page 83. That gives you an idea of how to do that in real life. Prone abdomen, so on page 116. This is less desirable if the kidneys are of interest because the kidneys are more posterior in our body. So doing it prone, prone abdomen takes the kidneys further away from the IR, thus making detail a little bit less. But if you're looking to kind of reduce part thickness, compress abdominal organs, and by reducing part thickness, you can maybe lower radiation to the person. If you need less radiation to get through the part, you can do this you can do it prone to achieve these things. Sorry. And then the CR is at MSP and at the iliac crest, just like with your KUB. Okay, finally the lateral decubitus. This is a picture straight out of your book. And the person is lateral, their body position is lateral, but now we have a horizontal x-ray beam coming in so that the projection is AP. So a lot of different terms to get used to there. Left lateral decubitus position, but an AP projection. Notice the right markers here, because this is the right side of the body. The left side is down. The left lateral best visualizes free intraperitoneal air in the area of the liver. And this kind of takes free air away from the area of the gastric bubble, so maybe the radiologist has a better chance of viewing it or visualizing it. In this case, you can either use the Walbucky, maybe the patient's on a stretcher and you've taken them over to the Walbucky, or set up your IR so that it's behind the patient. In our lab, for example, the IR, we need a grid over it. It's not in the bucky, it's just set up behind the patient with that horizontal x-ray beam. And then the CR is perpendicular, MSP as close as you can get. And then this line here, this vertical line, is 2 inches above the iliac crest, or superior to the iliac crest.